Yeah.
Okay. All right. So today we're going to talk about sex differences in science and medicine.
Yes, we are.
Okay. So lead the discussion, Sam.
Do you want like a more formal introduction?
Um,
Like this is episode 2 of the.
I don't think so.
Okay.
Do you think that helps? Do you think it helps people, like, what's someone going to do when they hear that it's episode 2? Are they going to go back and try to find it? Like, if it's episode 6, are they going to go try to find the other episodes? How does it benefit the audience?
I don't know. I guess I'm used to like hearing that from like the podcast that I listen to. Do you really want to hold that? You can hold your mic if you want. I would actually encourage you to. Yeah, hold the whole mic stand. That works too.
They need to hear me.
Okay.
They need to hear my opinion on women's issues.
Yes. Don't worry, guys. I will be leading the bulk of the discussion. Yeah, fine. That's a great introduction. This is just going to be like the first minute. I'm not cutting any of this out.
Okay. So now start the discussion.
Okay, today we're going to be talking about sex differences and disparities in medicine, research, and clinical studies. This is a very important topic, and I am 100% biased. I've spent the last 7 years in some capacity researching sex differences in physiologic variables. So I will give that caveat. So I'm really excited today to be talking about the broader impact of sex on, like social roles, gender roles, how patients are treated in clinic, how physicians are treated in clinic, and how we as a society might not take into consideration sex to the extent that we need to, or might over-consider it also. That's negative as well. So this is, of course, like a highly complex topic, and it's multi-layered, right? So like I just said, the bulk of my research is in the physiologic differences from like a basic scientist perspective, which is great and cut and dry and super straightforward. But I think it would benefit both of us and the audience to go through this from a macroscopic level and just go down subsequent levels. So
what's the first level?
First level would be societal, right? So time out. I understand that sex and gender are two very distinct things. Gender, of course, is a spectrum. When we talk about sex, we're not talking about gender. We're talking about physiologic, biologic sex. So XX, XY, and any iteration thereof. Unfortunately, some of these papers do conflate like
sex and gender,
or
right.
They'll just use the phrase man and woman instead of like males and females.
And are we talking about, if we're talking about sex differences, we're talking about typical sexes? We're excluding sort of intersex phenotypes?
Not willingly, but a lot of the research and publications.
But the things that we're talking about, they apply to
generally, yes.
The average example.
The binary that we are kind of all inundated with, unfortunately. I think that non-binary sexes or sexual characteristics should be its own podcast in and of itself, because those cases are going to be handled very differently.
But we are aware that there's non-binary genders, but there's also non-binary sex.
Yes.
Male and female sex fall on one side of the spectrum rather than the other.
Yeah. Broadly, we are considering female in this case to be XX individuals and males to be XY.
With typical expression of sex-related genes.
Yes, exactly. How has sex impacted you from a societal standpoint?
Well, on my videos that I post on the internet, a lot of people assume that I'm LGBT or that I'm a soy boy. I get a ton of comments talking about my gender expression.
Yeah.
And I'm a cis, straight man, and it doesn't bother me that they do.
Yeah.
But society, just because I talk about skincare on the internet, is trying to put me into a certain box.
Yeah. That's frustrating.
And it's just an interesting phenomenon. And to some people, that could be very restrictive if they're afraid of that kind of criticism.
Yeah.
Then they might not be who they want to be.
Yeah.
Toxic masculinity affects both men and women.
Yeah, that's a good point. That's a very good point. Yeah. From my experience, specifically in like professional or, like training or clinical settings, I can have a conversation with a male patient and a conversation with a female patient. The exact same things are being discussed, and they can take two completely different trajectories. And this is like a bi-directional phenomenon, right? Like it could be that males and females conduct themselves or respond to specific stimuli in a clinical setting very differently. It can also be my sex, right? Like they can be responding to me and the fact that I am female and I present as a woman and I am a woman that can lead to different interactions on that face as well. And I think this is definitely like a common phenomenon among like my female colleagues that some of my male colleagues don't have to deal with. But,
yeah. So I think there's definitely that. I mean, the typical example is, some of our female colleagues complaining that male patients assume they're nurses.
Oh, yes, for sure.
And I would have thought that we were beyond that.
Yes, I have never
in
once...
this year, but so many people I've heard complain about that very, exact thing.
Yeah, I have never once been mistaken for a doctor or a resident, but I have numerous times been in a patient's room and they have just assumed that, the male is...
You're a nurse? Oh, no, I'm in medical school.
Yeah.
Oh, you're in nursing school?
Literally. Oh, wow. It's kind of incredible, honestly.
Sorry, that was my masculinity coming out.
No, it's okay. That's okay. Okay, so yeah, like we know that, like sex and the way that we are perceived definitely affects us, like as medical professionals. I can't really speak to other professions or species, yeah. Species, like how sex might impact them. I'm just now overcoming this like imposter syndrome, and I really think that a lot of it had to do with being a woman in like a space that was dominated by men. The majority of the research that I did in undergrad was neurosurgery research. There were, in the department I worked in, there were maybe 2 out of like 20 neurosurgeons that were female. And yeah, it was
a lot of underrepresentation.
Yeah.
But at least in our graduate class,
yes,
I'm the only male.
Yeah, this is true. Yeah.
So you found your place.
I really did. No, and I have had the distinct privilege to work in an all-female lab for the first time in my life, which is and we study sex differences. So it's so cool. It's a very interesting space because we're very tied to our research in like a number of ways. Definitely, kind of advocating for research in this specific domain is huge. Going down a level. So like on an individual level, recognizing that people are different because of their biologic sex. That's kind of the next level down. And as future clinicians, this is important to consider, especially we're going to have to spend some time in internal medicine. So this is obviously like we're going to have to treat males and females, and just being very aware that there are distinct physical characteristics that one sex has that another doesn't. So if I'm doing an abdominal ultrasound on someone that is a female, granted, doing an organ inventory is probably a good idea for all of your patients, but without doing that, I would expect to see like a uterus, right? That's a very fundamental phenomenon. And just recognizing that there are these inherent physical differences, that would be like the next step down. And then going one step further, there are distinct molecular differences. Like I said, there are 2 sexes, XX and XY. That means that you have a chromosome that codes for genes that I do not have and my cells have never seen in their entire life. Actually, if they did see them in an inappropriate context, well, any context really would be inappropriate. My cells are not supposed to see a Y chromosome, but my immune system would like lose its fucking shit.
Are genes from the Y chromosome not slowly getting translocated into other chromosomes in the genome?
It is a possibility, but like generally...
That wouldn't affect your immune system because you would have been born with it if you were someone who had that translocation.
Yeah. Yeah.
I do see headlines about the Y chromosome shrinking.
Yeah, no, like loss of Y chromosome is actually, it's been used as like a biomarker in a lot of different cancer studies. Like the cell line that we use actually just published a paper about how like loss of the Y chromosome in this specific cell line led to different outcomes essentially in the disease progression. So yeah, the Y chromosome, especially given the fact that it's like this like little bitty, like dinky little guy, like it just like, it isn't...
Don't talk about my Y like that.
I'm so sorry, but it's definitely subject to degradation over time.
So when we're talking about loss of the Y chromosome, are we talking about degradation where these genes are lost, or are they being moved to other chromosomes?
We're talking about it being lost. From at least from the literature that I've read, we're talking about it being lost. I mean, translocation technically is possible. Like, I don't see why, like during recombination, you couldn't have some translocation going on. But generally, we're talking about like loss of Y, as in complete complete loss of the Y chromosome. It's really interesting too, because biologic females who have two X chromosomes, they are there's like this inherent fail-safe. Basically, if you have like an X chromosome that has a mutation on it and that gene is non-functional, your other X can like come back online and salvage that, which is useful. And it's something that men unfortunately do not have.
Yeah.
Wah, wah.
Yeah. So what you're talking about then is that because women have two X chromosomes, there can be genes that might conflict with each other on these chromosomes. So in each cell in your body, either one or the other is activated. So generally, you wouldn't have a cell that had both activated.
Yeah, it is possible to have both activated. Generally, only one X chromosome is supposed to be expressed. In addition to these like inherent molecular differences, which are super cool. This also reminds me of like the Four Core. Are you familiar with the Four Core Genotype? This is tangential, but it's super cool.
Don't tell me about it.
Okay, so the Four Core Genotype model was designed by these super kick-ass, badass researchers, and essentially what they did was they developed a model. Okay, so they translocate the testes, or the SRY gene.
Which is a gene that's found on the Y chromosome that determines the male sex.
Yes. So they translocated this to another chromosome. I think it was like chromosome 7 or something. So they would still get SRY expression in chromosomally XX mouse. So they can get physical phenotype of a male mouse that is XX.
Right.
You can also...
You can delete it in a male, and then they would be phenotypically female.
Yes.
Yeah.
Yes. That's the Four Core Genotype model.
Right, so it's the SRY gene, basically, that this is showing that's determining how a sex develops.
Yeah, so the point of doing this, though, is to show, it's basically to show that the X chromosome, or like X mosaicism, either impacts or does not impact certain things. I think it was specifically in like immune function. So if you have like two X chromosomes, but you still are phenotypically male, so you have like male gonads that are producing like testosterone, does having that second X chromosome actually do anything? Or are you okay?
I gotta sneeze.
You can sneeze.
I can't. Impermissible. Continue.
Are you just going to will yourself not just sneeze?
I just did.
Wow. Look at that, folks. Are you impressed? Are you impressed? That's incredible. Wow. Honestly, probably like one of the more impressive things I've seen you do ever. I'm serious. That's crazy. That's wild.
Continue telling me about.
Sorry. So the Four Core Genotype model, basically it's just a way to parse the interaction between chromosomes and hormones and what their impact is on specifically immune function from what I have observed and read about. But yeah.
So tell me about how that separates hormones and the genotype.
Yeah. So
are you giving hormones to the animals?
This is a great question. It depends on the lab you're in.
Because the SRY gene is going to determine the development of the testes, which is going to influence the hormonal profile, right?
Yes.
So if you wanted to test the differences between having the gene itself and hormones, then you'd have to give hormones or take them away somehow.
Yeah, it honestly depends on the lab. So there are specific iterations of the Four Core Genotype model that does do some form of like estrogen replacement. If you have like for a phenotypic male, or you can give like testosterone replacement in an XY lacking the SRY gene, an XY animal lacking the SRY gene, so a phenotypic female with an XY, you can like give testosterone to. It really depends on the question that you're asking. If you're asking from like a fundamental level, like does that Y chromosome have anything to do with the pathogenesis of like cancer, for instance?
Then you can give a female the Y chromosome without SRY. She'll still be female.
Yes.
But she may or may not have that effect on whatever you're looking at, cancer in this case.
Yeah, and I'm gonna, based on everything that I've read, if we're talking about cancer and we're talking about the immune system, it's hormones. There is some, like the X chromosome, I believe, encodes for TLR7, if I'm not mistaken. So you can imagine that if you have a mutation in a gene, in the TLR7 gene on your X chromosome and your XX, that you can shut that X off and bring the other one online, non-mutated form, your innate immune defenses.
Right. So women have some redundancy on any X chromosome,
which is huge.
Gene.
Yeah.
Yeah.
But no, going back to your original question, estrogen And androgens. I'm less familiar, like, because I have been working from like the female-centric model in a lot of my work. I'm mainly familiar with estrogen and the role of estrogen on a bunch of different things, but we're starting to like tippy-toe into what role androgens are playing. And there's a lot of really interesting androgen signaling, and we see mutations kind of cropping up in specific kinds of cancers that don't necessarily affect reproductive tissues, so that wouldn't have a ton of like androgen signaling going on anyways.
There's androgen receptors on immune cells like T cells, right?
Yeah, for sure. Mm-hmm. Yeah. And there's also estrogen receptors on immune cells, but hormones, specifically sex steroid hormones, are super, super cool because one, they are everywhere. They're fucking everywhere. Like every single cell has like an androgen or estrogen receptor of some kind. I say that with like 95% confidence about androgen receptors specifically, but 100% confidence about estrogen receptors. They're fucking everywhere. But they're super cool because estrogen is a steroid, right? So it's fat soluble. So it just like floats into cells and immediately like can bind to an estrogen receptor that then goes on and binds to your genetic information and starts affecting transcription. So it literally can turn genes on and off in very quick succession. Of course, there are like redundancies, and you have this gigantic hormonal axis that keeps everything in equilibrium. But generally speaking, estrogens fucking kick ass. I won't like wax poetic about hormonal birth control, but I really want to.
That was going to be my next question.
I'll go for it.
What does that mean about people who use hormonal birth control?
It means that we have failed as a society, that we are so reliant on fucking up something that is so good at changing our genetic profiles. We have failed. Listen, I'll say it again for the people. We have failed as a society for our primary form of contraception. I will acknowledge that there are use cases for hormonal birth control that make a lot of sense for a lot of people and that benefit people in incredible ways. But the fact that millions of people have to solely rely on hormonal birth control and it's kind of like prescribed rather willy-nilly is absolutely buck wild to me. Like it truly shatters my mind.
And what are the consequences of this?
Well, it depends on the individual, right? It depends on how sensitized they are to estrogen.
So what do you think we should do then in terms of contraception?
Mandatory vasectomies.
Mandatory?
No, I'm just kidding. I'm totally kidding. I would love to get like baseline estrogen and progesterone levels.
So for someone who was seeking out birth control, they would get baseline estrogen and progesterone levels before you would prescribe?
Yes.
As a policy?
Yes. Yeah. Because,
but wouldn't that reduce access?
It depends on your infrastructure, right? Like there are certain testing guidelines that are very amenable to, like how many millions of Americans are being placed on statins that are from lower income, or it's as easy to test your serum levels of FSH, LH. You can take a urine test for LH, and if that's...
And so who would be appropriate then for birth control in terms of what the result was on the estrogen and progesterone test?
Well, it's not even a question of who would be the ideal candidate, but like this is assuming that we're entirely reliant on hormonal birth control, right? For instance, I can take Lipitor and I can take it at 5 milligrams, 10 milligrams, 15 milligrams, 20 milligrams. I'm also making up these numbers because I've been out of clinic for a while, so I don't actually know what the actual...
Right, so you can take different doses, and you're saying that the dose is standardized for hormonal birth control, which means that some people could be taking a fraction of the amount they're taking with much fewer side effects, but we don't even test or bother with that.
Exactly.
Is what you're saying.
Exactly, which is mistake number one. Also, I think, again, sex steroids are incredibly potent, incredibly powerful.
Yeah. We kind of do that in a backwards way. Like if you're having side effects with one hormonal birth control, you would get switched to a different one.
That's a great point. Highly inefficient. highly inefficient. Also...
But what readout would we know whether someone was going to need more or less? Based on weight or based on their initial hormonal profile?
I honestly, I think getting a baseline... So if you are with an OBGYN that you trust, for instance, and you maybe spend a month doing cycle tracking. So that basically is just saying you can do things like checking cervical mucus, checking like basal body temperature and other like signs that this is where I theoretically would be in my cycle. And based on what we know about the menstrual cycle, and this, of course, gets a little hairy if you have like an irregular menstrual cycle, but based on what we know about the menstrual cycle and about these hormonal fluctuations, I could pick a time, let's say, you know, like right after menstruation when I think that my estrogen or progesterone should be within a specific limit, or it should be generally like plateauing or slightly increasing. I could get a blood sample then, and then when estrogen is peaking at ovulation, I could get a blood sample then, and just to kind of know what that delta E is. So you're not like just throwing synthetic estrogen at someone and spiking their estrogen through the roof and causing all of these issues. Same thing with progesterone. Progesterone has like what are commonly associated with like negative symptoms. So it's the hormone that makes you feel like bloated and kind of tired, and you're like, "Mwah."
I've read about men who take progesterone for sleep.
Interesting. That's interesting, actually. Yeah. Is it a singular like biohacker, or is it like someone that was prescribed progesterone?
Someone who's prescribed progesterone, and I've heard Dr. Will Powers, who I believe is a family medicine practitioner, but he does a lot of like gender transition therapy, from what I can remember.
Oh.
And he likes to experiment with some of the compounds that he gives to his patients just to see
I love it.
What they do to his body, you know, in a sort of educated context.
Yeah.
And so one of the things that I saw him talk about.
Wait, who is this?
Dr. Will Powers.
Okay, Will Powers. Shout out Will Powers. That's cool as fuck. That's awesome.
Was that he was talking about the effects of progesterone and how it may improve sleep.
Yeah. Yeah. There are a lot of interesting use cases. I mean, even if we're like a little bit more cognizant of how specific sex hormones affect us, like that could be huge, right? That can like help like a lot of people struggling with insomnia that may not have, like, I don't know what like the long-term side effects are for a man that is taking a dose, presumably low dose of progesterone, but I mean, yeah, if you can find a benefit for these hormones outside of their typical use in like contraception or IVF or whatever, that's the beauty of things. That's the beautiful thing about doing this kind of research is it opens a lot of doors that, you know, had otherwise been closed due to ignorance and bias.
Definitely. And what do you think about male birth control?
I think male birth control is a really interesting concept. The one that I have researched the most, I guess, is the like injectable
the polymer.
Right? Yeah.
That can so there's like an injectable polymer that you can put in the vas deferens, which is the sort of pipe that the sperm flow through.
Yeah.
And one of the problems with a vasectomy, from what I understand, is that when you cut the vas deferens and close it up, your sperm is still being produced. Yeah. And in some cases, your body can form an immune response to all the sperm that's building up. And this makes the vasectomy irreversible, because even if you reconnect the vas deferens, your production of sperm and the health of the sperm are going to be affected long term. Okay. So the polymer hopes to solve that issue by being sort of porous, so the sperm sort of get torn up as they go through this porous polymer.
That's awesome. And
so they can still be ejected.
That is such
just
a cool...
in a non-functional way. So that is cool, but it's
for women, for instance, like what is preventing us from exploring like options for like a cervical cap that kind of emulates that? Basically like a dissolvable polymer that is slightly porous. Menstruation would be like the number one thing that I think might present some difficulties, but if you have like a slightly porous
You mean like in the fallopian tube, in the tubes?
No, like a cervical cap that you can like insert. This might be a multi-billion.
Insert yourself?
Yeah. I mean, okay, women are expected to shove a bunch of shit up there. Also, IUDs, don't get me started about IUDs. You're never fully prepared.
What biological process could you be interrupting by doing that?
By doing what?
By putting a cervical cap on.
Well, fertilization would be the
well, I mean, that would be the one we're intending, but besides that, I mean, is there any type of
menstruation? You would like theoretically interrupt menstruation.
What I'm interested in, what I find interesting is that we have sort of good pharmacological male birth control. You give men male sex hormones, right? And so what this does is it goes to the brain, and your body sort of detects that you have these hormones there. And your brain normally sends two hormones, LH and FSH, which is like a message that they send to your testicles or ovaries to do all sorts of things, but including produce sperm.
Yeah.
Right. So someone who is using anabolic steroids is generally sterile while they're using them.
Yes.
So there's been developed in a lot of science on this where they give men certain anabolic steroids and to make them sterile at doses that aren't necessarily going to harm their body, like the ones that they use for bodybuilding. Right. So there's one called Ment. I think it was called. The drug name is Trestolone. I don't remember exactly, but it worked extremely well. So it's like over 90% efficacy, and so you just need to give men these male sex hormones and then test to make sure that their sperm aren't viable. They have azoospermia, meaning no sperm production, which is about like a 90% chance or more. And I just find it interesting that we don't do that, right? And so the argument is like you have these effects on the body, and in general, like a lot of men would appreciate the increased muscle tone and things that they would get from these drugs, but there's also downsides like increased risk of heart disease depending on your dosing schedule and things like that.
Yeah.
So that's the argument. Like we don't want to give these dangerous hormones to men to prevent just for birth control, but I mean that's what you're saying we're doing to women anyway.
Oh, we are.
So it's like
we're doing that
it's a double standard there.
For sure. I was not aware that this was extensively, again, like I'm coming from a female-centric place, and I'm going to recognize my own bias because I haven't even considered the idea of using like sex steroids for men to render them sterile. And I'm assuming a reversible process.
Yeah,
right?
there was one, at least for testosterone use. Like I don't remember what the result was in terms of the MENT study that I was reading, but there was a study where they looked at people who were on testosterone, and they were all sterile. They were all fertile in the beginning, and then they just stopped them abruptly. And after 2 years, all of them had their fertility restored. So some of them took a long time. Some of them regained fertility right away. But it seems like this process is reversible in a large majority of men, at least.
Wow. That is something.
And if you then add other things too, we could study the different aspects of this to improve the fertility and to regain function after you stop too. Like there's protocols that people use after they've been using anabolic steroids, like they'll use clomiphene, or they'll use they'll use HCG to regain function of their testicles.
Wow.
And so there are these options for men. We just don't use them because no one wants to mess with the hormones of men.
That's it, folks. That's it for me.
Yeah.
Honestly, because I've been complaining about birth control and the fact that we have to subject as a female, ourselves and our patients to this kind of like, it works. That's the thing. It works. It does. If you do it correctly, it works. And that's the only thing we care about. And it's utterly insane because there are like significant downsides to using hormonal birth control for a lot of women. Not to mention like the only like super effective non-hormonal form of birth control, if we're talking about like a long-term birth control, is a copper IUD, which is, if you are a female and you're listening, you understand exactly why I think it's comical that is our response as a society, is a piece of metal shoved into your uterus to induce inflammation.
So in terms of the negative effects of birth control, after a woman stops using birth control, is there sort of a post-birth control syndrome, or
There can be. Like if you are someone that, like, let's say you like really benefited from birth control, it like helped your PMS symptoms. It helped, like, if you had like menorrhagia, so like super heavy like periods, you can have a rebound of some of those symptoms. But for a lot of women, you feel better. And like your cycle resumes and it's normal. It also depends on how long you've been on birth control. So if you've been on birth control for years and years and years, and you stop it, suddenly, you can expect some side effects for sure in terms of crippling depression, mainly.
Yeah, I think there definitely should be more awareness in terms of what the side effects of birth control are. So that women can make an educated decision, because I think a lot of times even physicians will say that the side effects are minimal.
Which is unhinged. It's like, it's truly a wild statement. It's such a wild statement. And they're, like you said earlier, they're...
But I also wouldn't want to do anything that reduced access to birth control either.
Yeah. I don't think it has to be that
as long as women understand,
trade-off.
What these hormonal modifications are doing to their bodies.
And also I would like to say, like, I'm like really railing on like hormonal birth control, but please use birth control of some form or fashion if having a child is not right for your lifestyle. Like, I'm not saying don't use it. It's the best option that we have available.
Right.
And
women just need to be able to weigh their options with information that they oftentimes don't have.
No, yeah. And it's honestly kind of egregious that even as, like, on OBGYN, we were taught some side effects, mainly don't give progesterone-only birth controls to overweight or obese patients because it makes you really hungry and it makes you gain weight, and that's bad. I mean, yes.
Be careful of anything that makes anyone gain weight, though.
Yes, I understand that, like, weight gain can be like a really, really troublesome side effect for a lot of women, and it obviously like negative health ramifications.
It seems like you're implying that it's like we're doing that because of some sort of female body standard.
I mean, it kind of. Okay, I shouldn't say it kind of felt like that. I understand the rationale, but if this person is like, I want an implant, give them the implant. And if they are like, if there's a dosage issue, we should work through that. There are just a lot of like interesting things that crop up when we're talking about women and sex, having sex, being responsible about it, having kids, and potential side effects. Thank you. Thank you for that.
We can't let people forget what we're talking about here.
Yeah, exactly. But yeah, it's definitely a reality that I don't know. I think this conversation has made me even more aware of.
Yeah, it's upsetting. I find the lack of male birth control options upsetting too.
Yeah. Like, aren't you scared? Like, everyone could benefit, right? If we had like more safe, effective forms of birth control that are available to everyone. Because not to say that some people are like non-adherent or whatever, but there's always a certain like mental, psychological obstacle that you have to like overcome when you are like sleeping with someone, or there's a certain degree of autonomy that like over your like reproduction that, like I could see like males definitely benefiting from that.
Yeah, I'd love it.
Okay, I'm glad. Yeah. Wow, we really went off on a birth control tangent.
I think it's important, and I think a lot of listeners, it's relevant,
Oh, for sure. And it's literally, this is...
Because we're not all in a lab just moving SRY chromosomes around, or SRY genes around.
Yeah, I know.
But a lot of the listeners and people do take birth control or know someone, their partner may take birth control, so I think it's relevant to a lot of people.
Yeah, and it's so funny, too, because I've literally been complaining about birth control for the last, like, 2 months now. I'm just, like...
Complaining to who?
Just the universe.
Right.
Like, my PCP, my friends, my mom, anybody who will listen. Yeah, because it's truly, like, from a personal, and I don't care, whatever, you guys can know everything about me, I don't care. It has been a nightmare. It really has been. And it's just, especially,
So your experience with birth control was negative?
Yeah. Oh, for sure. First of all, like, in terms of like lack of access, because I know that like I don't respond well to hormonal birth control in any iteration, which is really upsetting because like my hormones, they're like at baseline, they're just such champs. And I love them so much. Like, I love my estrogen.
Hormones are perfect.
They're perfect.
Don't you dare touch them.
That's what I'm saying.
You stay away from my hormones.
That is what I am saying. They're perfect in every fucking way. So, like, of course, I explored, like, non-hormonal birth control options. And, like, you have, like, if we're going to exclude ones that are, like, from the 1970s to 80s, so, like cervical caps and spermicidal foams, like there are relatively like new takes on that, I guess. Like
new foams?
Well, there's like, oh my God, this is actually so fucking chaotic. Okay, so there's like an acidic solution that you can kind of just like shove up into your vagina before you have sex. And that's literally its job. Its job is to be an acid in your reproductive organs, which like, one, your reproductive organs as a female, biologic female, if you still have a vulva, still have a vagina, still have a uterus, that is very tightly regulated for a reason. Your internal pH is tightly regulated. Any perturbance to that, myriad things can go awry. So the fact that our biggest advancement recently in birth control is a tube of acidic jelly that you can just shove up into your vagina before you have sex. Ludicrous. Absolutely wild.
What are the side effects of that?
It can just it's like only like 74% effective, which is, you might as well just like pull out at that point. I'm pretty sure it's the same stats. But I think pulling out is more effective than that. Yeah, if you do it. I think if you do it right, I think you're right, honestly. But
you could have some redundancy. You could have acid and pulling out.
You could have acid and pulling out. That is very true. Yeah, I guess that's your solution. Acid and pulling out.
Yeah.
Yeah. No, but like in addition to like not being super effective, it just like opens you up to a bunch of different like one, irritation. Irritation's a big side effect because again,
what's the prevalence of that side effect? Is every woman who uses that going to experience some amount of irritation?
I would be hesitant to say that every woman is going to experience some form of irritation because that just doesn't really happen. But I think I would say, I have no idea what these numbers actually are. Don't sue me, but anywhere from like 20 to 40% maybe. So a significant chunk of women. And also it just opens you up to a bunch of different like infections. And yeah, that's unfortunate. It's really unfortunate. That is our biggest advancement recently. Yeah. And I think that's all I have to say about. I already screamed at you about copper IUDs, right? And how unfair those are.
You don't like them.
Yeah. Oh, like lack of access. Okay, so personal experience again. I actually was planning on getting a copper IUD, and I went through this whole fucking process. And this is before the clusterfuck with Planned Parenthood. I don't know how Planned Parenthood is doing right now. I have no idea. It's been really hard for women's reproductive rights. But I basically had to go to like 3 different Planned Parenthoods and almost had to pay $1,200 out of pocket to get a copper IUD. But they have like specific grants. Also, if this is a viable option for you, if you're okay with the side effects, if this is good, there are grants out there that will allow, women, specifically women that are, like not making significant income, aka undergrad student, that will like fund that, that will pay for you to get a copper IUD. But I went to a Planned Parenthood and literally waited for like 3 hours, and they were like, "You got the grant, can't do it at this location." So eventually I just gave up, honestly. And then I went on like one of those like online like birth control places that'll like mail you birth control. And I've been just pinballing different options, and they all suck, for me at least.
Because you're a hormonal specimen.
I am. My hormones are perfect. Please leave them alone. Yeah. Don't touch them. I do great. Like, So that's my own personal experience. Yeah. It's a fucking nightmare.
Yeah, there's definitely room for improvement.
For sure. So if you're out there and you're listening and you have like a background in like bioengineering, look into like polymers, please. I was like really considering doing something with it. I don't have time, the energy, or the background for
polymers for women?
Or men. Any kind of. I'm really thinking about like a biopolymer that like for women, if you're using with cervical cap, has a specific like binding site for an enzyme found in blood. So when it's exposed to blood, it like dissolves. I think that would be, and there are like in surgeries, you can it's the opposite, right? So when it is exposed to blood, it solidifies and polymerizes. So with my limited understanding of how these things work, why can't you just have the opposite happen, right?
Right.
And assuming there's no like trauma or anything, like your vaginal canal, your cervix doesn't have any blood exposure. I mean, so this is our next segment, disparities in clinical research, and we may or may not stay on topic. But I think that we can both agree that women are generally underrepresented in clinical research. And it is not only dangerous, but just fucking annoying. It's annoying from like a basic science, clinical science perspective because...
Right. And when you say underrepresented, what does that mean?
Oh, yeah. It just means that you don't have women in your studies or not enough women.
Right. So when we study something, maybe a drug or something like that, we'll get a bunch of male participants and give them the drug. And oftentimes, at least historically, we would just extrapolate that to women. So men would be in the drug trial, and we say this drug works at this dose for these people, and maybe it does, maybe it doesn't work at that dose in women or at all. But we historically just wouldn't have known because there's so many more men in these clinical trials than women. Yeah.
And what do you think is I have my own perspective as to why there's like this gender bias, but why do you think there's this gender bias in clinical studies? Like, is recruitment different, or are exclusion criteria different, inherently different? Like, what would make a researcher say, I am only going to look at something happening in men? It's just, it seems like arbitrary and it seems stupid to me, but like, what is the rationale?
I don't think there was like a clinical rationale. I think it was just men were the one doing things. So the doctors were men, they worked with men when they were recruiting. I have no idea, but when they were recruiting, they probably just talked to men.
Yeah. I know that in terms of like animal studies, at least, like one of the reasons that like female animals are excluded.
That's true. Because of the menstrual cycle, they think that the hormones might affect something.
Yeah. Which, I mean, fair enough, they do, but if you are going to take this and apply it broadly, and you're operating under the same assumption that like half of the population is going to have a menstrual cycle that may affect this process, what the cognitive dissonance of it? Like, I don't get it. I really don't. And there's also the reproductive potential of females. People that,
so we're talking about if there's a clinical trial, we don't know whether or not it's safe for pregnancy yet. Yeah. If it's going to affect the fetus, then we want to test that on men first, who definitely aren't going to get pregnant. So that's not a concern, is what you're saying.
Yeah. And it's that in and of itself is like so interesting, like how women are excluded from, or how female patients are excluded from clinical studies and clinical trials because they might reproduce. So then, as a result, pregnant patients are kind of fucked, because like nothing has been studied in a pregnant population. But it's kind of like weighing the risk of potential reproductive outcomes. And I know that there's a time and a place, but given what we know now about how a lot of things affect reproduction, there's a lot that we know about human development and what is required to have a healthy gestation. And I think that we can be this is going to be a controversial take, a little less conservative, because we are fucking pregnant patients, and we're fucking pregnant patients from...
Oh, I haven't.
Okay. I mean, I haven't either. But we are fucking them over, I should say. Yeah.
So tell me about this study in COVID.
Yeah. So this is just a meta-analysis that I dug up. It's called Sex, Racial, and Ethnic Representation in COVID-19 Clinical Trials, a Systematic Review and Meta-Analysis. So I will just hit the key points. But we already talked in our previous episode. We talked about meta-analyses and what they do. So meta-analyses take a bunch of clinical trials and articles and make exclusion and inclusion criteria to figure out which clinical trials and which results they're going to use in their final analyses. And so...
Right. So what they're doing here is they're just looking at a bunch of studies, and they're excluding ones they think are bad and don't belong or aren't relevant to what they're trying to say. And then they sort of lump together all the results and try to make a conclusion.
Yeah, because it boils down to having multiple data points, right? So what they're trying to show here is how well represented are categorically underrepresented groups. How well represented are they in these COVID-19 clinical trials?
And these were clinical trials for drugs or vaccines or both?
So these were clinical trials for... So I think it's literally just all COVID-19 clinical trials. Yeah.
And what did they find?
So they
in terms of women?
Oh, in terms of women. Yes. So for treatment, also I want to say that, like, they're comparing like the number of women in the trials to the number of women with COVID in the population. So it was 48.9% in the prevention trials versus 52.4% of females in the U.S. population that had COVID. So, about a 4%.
More women had COVID than men, but fewer women were in these trials than men.
Yes. Yeah. And then in terms of treatment, 44.6% versus 52.4%. So that's almost like 8% difference. Yeah, 7.8% difference.
Do you think that difference is enough to affect, clinical decision making?
This is actually like a better balanced study than I'm accustomed to seeing, to be quite honest. Normally, we're looking at like 10 to 30% female representation. So this is doing a lot better. I don't think that it would dramatically affect anything.
And what reason did the authors give for why this difference existed?
A lot of it boils down to like recruitment. They need a certain number of people, and the people that ended up in these trials were white men. Because the other part of this is sex, race, and ethnicity. And I do want to take this opportunity to say that women are underrepresented in medicine. But if you are at the intersection of, being Black and being a woman, for instance, or Black and female, you are really, really up against a wall. They are historically and currently like mistreated and underrepresented, and a lot of the clinician or like explanation kind of revolves around distrust, like medical distrust. But time and time again, we have given a lot of these individuals absolutely zero reason to trust medicine. But hopefully that changes with the coming generation of healthcare workers. I just wanted to make that known. And it's not just Black women, of course. It's, Hispanic women or Latino women or Native women. Any, that intersection is pretty brutal.
Right.
Yeah. So the conclusion was basically, these underrepresented groups are also underrepresented in the COVID-19 clinical trials. And that was what the authors landed on. We can definitely do a better job, especially as two people that are going into a profession where we're likely going to be doing a lot of clinical research, to ensure that our clinical studies and even like basic research studies are inclusive and are reflective of, the actual like sex of a population. You know what I mean?
Very important.
Yeah.
So now let's go to segment 3. We're talking about sex studies in addressing sex differences and disparities.
Yeah. So this is actually kind of cool. So this is something that we can go through like rapid fire. So like I wanted to give our listeners like concrete examples of how this difference and these disparities are actually manifesting themselves. So for STDs, specific kinds of STDs were thought to be more prevalent in one sex versus another. And again, I don't have the stats in front of me, so I can't tell you like what the direction of this relationship is. But so there are inherent sex differences in the modes of transmission, but our clinical trials and clinical studies haven't reflected like an equal distribution of like STDs. So like basically the actual sex differences in a population were completely missed because they were offset in the clinical trial design, if that makes sense. So that's STDs. Chronic pain, this is a big one. This is a huge one, actually. And I've seen it like play out in clinic. Studies have found that doctors often view men with chronic pain as like overcoming a certain like amount of adversity. Like, oh, you're brave. Oh, you haven't had your hip replaced. I'm talking about my actual father, who was in chronic pain and was kind of just like saluted almost. But women with chronic pain are often viewed as like emotional or hysterical or overdramatic, and are also way less likely to actually receive any kind of like pain control measures. It's kind of wild, actually, the under acknowledgement of pain, especially like in like a surgical setting. Women are far less likely to receive, at least as of maybe like 5-10 years ago, far less likely to receive a prescription for adequate pain control compared to male patients, which is so problematic. So autoimmune conditions. This is a huge one. This is a huge, huge one. 75% of people with autoimmune conditions are women. There is a physiologic reason for this. It's because women's immune systems are kick-ass. And they are super robust, and they fight off everything. Unfortunately, they can overshoot it, right? So women are afflicted with autoimmune diseases. But 62% of people with an autoimmune disease have been labeled as like chronic complainers or hypochondriacs, because a lot of autoimmune conditions can have like these really weird systemic symptoms. It's like it's a dismissive attitude, and autoimmune conditions, which just overwhelmingly affect women, are where we see the most dismissive like response by clinicians and doctors. It's the most underdiagnosed condition, like chronic condition, that we see. And yeah, it's super interesting to me that it only, I shouldn't say only affects women, but it definitely disproportionately affects women. So COVID-19, this is going the opposite direction. But men had a higher mortality rate than women. And this is definitely a sex difference that we have heard all about. Super interesting how that works. But no, men are more likely to die from COVID-19, at least at its peak, and more men did die of COVID-19. And this is when other factors like environmental and behavioral factors were controlled for. So like things like smoking or environmental exposures.
So this is due to men's immune response not being as strong, you're saying?
Yeah.
Hypothetically.
It's not hypothetical. Yeah, it sucks. Sorry. But it's like evolutionarily advantageous to have like a decreased. It's actually really interesting. Have you like heard about any of those like evolutionary theories about like why men have like decreased immune responses to things like parasites and viruses?
I don't know. Tell me.
So one theory that I heard, there's like a better one out there, but like one that I heard was that it's almost like machismo. It's like I'm able to like survive and court a partner, like a mate, despite being like riddled with like parasites and viruses. I know it's so like counterintuitive and kind of loopy, and I was like, that is such a hot take.
I don't know about that one.
No, I know. I don't necessarily agree with that either, but it does have to do with like reproduction, and yeah, it's interesting. I don't know.
Okay, what's another one then?
I honestly like can't. That's the only one I can think of. It's like all of the other like decent theories, like kind of like heart attacks. So heart attacks are underdiagnosed in females. So females are actually, unfortunately, more likely to suffer negative consequences from MI, myocardial infarctions, relative to their male counterparts. And then sepsis and septic shock. So male sex has been identified as a possible risk factor for sepsis, and something tells me that it has to do with the fact that they don't have as robust immune responses. But that's kind of interesting, though, because you would expect, like, because sepsis, what kills you in sepsis and septic shock is, like, your inflammatory response, right?
Right. But I think that's in response to the bacteria being able to proliferate in your blood.
Yeah, that's fair.
So if they weren't able to do that in the beginning, like in the first place, then you're not going to have sepsis.
Yeah. And then finally, cancer.
And if you do, it doesn't matter. I think if you're male or female, you're going to have a bad time if the bacteria do start proliferating in your blood.
Yeah. Yeah.
So now we're talking about cancers.
This is my sweet spot. This is my home. Men are more likely to be diagnosed with literally every kind of cancer. Okay, I shouldn't say literally because,
what about testicular cancer?
I know, ovarian cancer versus in non-reproductive tissues, men are more likely to be diagnosed with cancer. And this is something that I think is under-discussed. And it's really interesting, too, because, like, I don't want to get, like, too into the weeds about, like, what my actual research is about. But it's really interesting because we see a higher incidence in males, but we also see, like, worse outcomes for females. And this has to do with, like, a number of really complex processes that occur. But again, if you're just looking at males and their pathogenesis and kind of taking that and placing it on, like, you're going to see in your population very, very different outcomes. All of these examples are just to kind of give you guys, like, a concrete idea of very real ways that ignoring biologic sex and assuming that we're all kind of built the same is really harmful. It's not only harmful to women either, it's harmful to men as well. Or females, males. There I go, conflating gender and sex. How do you think we should go about addressing these kinds of disparities? Like, do you think, like, governmental bodies or institutions should be, I mean, the NIH just did.
Yeah, I mean, to get funding from federal sources, I think there could be some guidelines in terms of, you know, what the sex ratio and things needs to be in clinical research.
I don't think people should shy away from having sex-specific treatments to things like cancer, right? And I know that there are, like, but those are reproductive tissue treatments. But I don't think that, like, people should shy away from isolating a sex or isolating sexes, determining what they respond to, and then, like, putting all of your effort and all of your resources towards a treatment for urothelial carcinoma in females only. I don't think, and I think that should be incentivized, if anything, because it is common sense that you would have very different responses to sex-specific treatments, or at the very least, like, figuring out, like, what those differences are in the first place in the process of diagnosis. You know what I mean?
Okay, and what are then our concluding remarks here?
So we spent a lot of time talking about birth control, which I appreciated. It was like a therapy session. You guys really got some insight into, like, what I've been bitching about for, like, the past, like, 2 months. And I thought it was, like, really productive too, because again, female-centric worldview. And it was nice to get your insight. And I'm going to go home and I'm going to read about some freaking testosterone, or what was it?
Ment.
Ment?
MENT.
Nice. Okay. Is one of the adverse effects of that.
But even that, like, if you're talking about, like, testosterone replacement therapy, there is some large percentage of men that...
Are there behavioral side effects?
There can be. It's more complex than it's not as simple as people become more aggressive. But yes, there are changes in behavior when you put men on steroids or testosterone. Yeah. They're not always negative. But like I was saying, these are the reasons why we don't use that as a birth control. But it's the same thing in women. It's the same thing. We give women hormone. There are potentially behavioral effects on women of the hormonal birth controls. So those are just things that I think that we could have an option for men and women, and we would weigh the pros and cons for each individual in terms of the side effects.
Yeah. No, I agree. Thank you for like just being such a STEMinist over here. Like, I really love that. Like, that's awesome. Yeah. What else did we talk about? We talked about general clinical study design. When you exclude one sex, you're also you're fucking shit up for everybody. I'm cursing a lot on this. I'll bleep it out. Should I bleep it out?
I don't know.
Okay. We'll roll with the punches and see what happens. But yeah, it really messes up our understanding of what's actually happening when we exclude, like, we might actually completely miss a treatment that's effective for men if we are only looking at women, and vice versa. Because, you know, like, if you're looking at a group as a whole, again, like, now that biological sex is a variable. And that's the other thing I wanted to say briefly, is that just because biologic sex is a variable, it hasn't done enough. Because yes, we can now stratify our participants and say, like, okay, how did this group do versus how did this group do? And you can say, like, females were 75% responsive, males were 100% responsive. That's a big difference. And if you're seeing that recapitulated consistently, or like, we only found statistically significant results in the female population, and then which goes back to like one of the papers that we had to read earlier this year, and then the author completely like glided over, didn't mention it not one time. It was like a huge trend, didn't mention it a single time. So yeah, I think we also need to like encourage researchers to explore these sex differences and incentivize them in other ways. I mean, the government, right, you know, has.
I mean, a lot of studies are going to have that data, and they don't even analyze it or present it.
Exactly. Yeah. And it also makes things difficult, like, for someone that studies sex differences, because even if you guys don't want, like, even if you're a researcher and you happen to find a sex difference and you gloss over it, or you don't discuss it, or it's like, you know, like, it just pops up and it fades away, that's going to make my life so much harder if I'm looking for a specific sex difference. If I'm looking for any literature anywhere that shows that checkpoint is different in males and females, and there might be a huge difference in this specific kind of cancer, and you guys just, I keep saying you guys, I'm sorry, I'm not trying to project, but yeah, I would just encourage people to be a little more emphatic, follow up if they can. If they can't, just be a little more emphatic and discuss those differences.
Okay.
Yeah.
Well, this was a great discussion.
Yeah. It was literally just me complaining the entire time, but.
Well, you have a lot to complain about.
Yeah. No. Being a woman is great. Being female is great. I thoroughly enjoy it. I just think that it was a little bit more fair sometimes.
Right. There's always things to improve.
Yeah. Thank you for being a friggin' awesome STEMinist.
Okay.
It's great.
Well, thanks for listening, and we'll see you next time.
Yeah.